Well, welcome everybody to the monthly UCSF-Stanford CERSI FDA Distinguished Speaker Series on Cybersecurity for Biomedical Engineering. I am Professor Kevin Fu from Northeastern University. So again, welcome to the first monthly seminar of the new year in 2023. And it's my pleasure to introduce the seminar series and our speaker for today, John Riggi. First, a disclaimer. This seminar series does not represent official FDA policy or guidance, and the contents are those of the speaker and do not necessarily represent the official views of, nor an endorsement by FDA, HHS, or the US government. This seminar is being recorded. I'm your moderator for today, a professor at Northeastern University in electrical and computer engineering and the Curry College of Computer Sciences in Boston. I am connecting with you today from Northeastern University's Arlington, DC campus. A few words from our sponsor at the FDA. Just a note that if you are interested in a career in cybersecurity FDA, they are hiring. You can contact Diane Mitchell at diane.mitchell@fda.hhs.gov. So why are we here today? There's been a lot going on in medical device security. You may have heard last year that some ransomware hackers had a bit of a schism, and they actually outed each other. And one of the Russian hacking groups was outed, saying that they're going to cause panic at more than 400 US hospitals. What does this mean? This means that the threats are no longer theoretical. These are no longer simply kids in their basement trying to cause chaos, but these are nation-state level sponsored hacking groups. So what's going on with cybersecurity and how do we build security in from the get-go? Well, there's been quite a bit of activity over the last year at the Food and Drug Administration and in Congress. 2 years ago, we saw an executive order from President Biden on improving the nation's cybersecurity, introducing interesting requirements such as SBOM and threat modeling for devices sold to the US government. We also saw the introduction of the Patch Act, which morphed into an interesting version that I'll talk about in a moment with the omnibus bill. We also saw last year that the FDA issued draft guidance on cybersecurity in medical devices, quality system considerations, and content of pre-market submissions. What does this really mean? It's pre-market security, what's recommended or expected for pre-market submissions before marketing a medical device in the United States for cybersecurity engineering. This is still draft guidance, not yet finalized and not for implementation, but it's FDA telegraphing what it plans to have for its thinking in the coming future. Now, most interestingly, though, less than a month ago, US Congress passed the omnibus bill. Inside that bill of December 2022 were several pages relating to medical device security. If you search for the omnibus bill and medical device security, you can find many articles online. Suffice to say, medical device security is no longer optional or simply recommended. It is now required by statute, required by federal law for review by FDA. And from some of the public news reports, you can see that FDA will be studying this law and will likely be issuing new information in the coming months about how it plans to carry out its new legal authorities for medical device security and pre-market review. With these big changes, it gives me great pleasure today to introduce our speaker, John Riggi. He's the National Advisor for Cybersecurity and Risk from the American Hospital Association. He's going to talk today about cyber risk and impact to patient care, a medical device imperative. John has a highly decorated background, working 30 years at the FBI, and now serving as the first National Advisor for Cybersecurity and Risk at the AHA, which represents more than 5,000 member hospitals. He's got a long and decorated past, including the FDA Director's Award for Special Achievement in Counterterrorism and the CIA's George H.W. Bush Award for Excellence in Counterterrorism. Without any further ado, I would like to give you John Riggi and hear his remarks. And thank you so much, John, for taking the time to join our audience today. I know we're excited to hear your perspectives, and questions are already coming into the Q&A system. And again, for any attendees who are looking to ask questions, please use the Q&A function as the chat function is not functional in this large seminar. Let me stop sharing and welcome, John.
Thanks, Kevin. Great to have this opportunity here today to present with you and be associated with the great work that you're doing with CERSI, work you've done at FDA and Northeastern University, of course, UCS, University of California at Stanford, and Northeastern, as I mentioned, my alma mater. So I don't want to say what year I graduated from the College of Criminal Justice there. Let's just say I did not have a laptop in my book bag. I actually had books in my book bag. So it was quite a while ago. So today we're going to talk about the increased cyber threats, specifically targeting healthcare, specifically targeting hospitals and health systems, and ultimately what the impact of these threats are. We have come to learn the painful lesson that cyber risk in healthcare is not just an IT issue. It is an enterprise risk issue, which impacts every function of the organization. And most importantly, it impacts the ability of hospitals and health systems to deliver patient care, and it does present a risk to patient safety. So I'm going to get in here to start sharing my screen a bit. So let's start with just a few foundational thoughts about technology and medical technology before we get into some more of the technical issues and the more tactical issues. Think about how technology these days in the healthcare environment literally encompasses everything we do, especially as we move rapidly towards clinical integration, cloud technologies, interoperability of medical devices, digital transformation, the use of artificial intelligence within the hospital and healthcare system setting. Now, these are good things. The use of technology within healthcare has certainly improved patient outcomes and has increased business and clinical efficiencies. However, the heavy use, integration, and reliance on technology has introduced significant cyber risk into the healthcare environment in two primary ways. One, the technology itself contains technical vulnerabilities. All technology contains technical vulnerabilities. That's why we are constantly patching and updating our technology and our medical devices. Those technical vulnerabilities are then constantly being targeted by our cyber adversaries to exploit those vulnerabilities and deliver malware into our networks, which could either, one, steal bulk patient information for sale on the dark web, and or deliver highly disruptive ransomware, which could interfere with patient care delivery, causing a delay again to care delivery and risking patient safety. There's another type of risk that the heavy use and reliance on technology introduces into the healthcare environment. It is certainly more abstract, but potentially more dangerous. And that is our operational and clinical dependency on the availability of that technology to perform our functions. If any of you have had the unfortunate circumstance to be in the midst of a ransomware attack, you suddenly realize how much you depend on technology to do your job, to deliver care, when that technology is no longer available. It's like being in a blackout when you suddenly realize that all the things you depend upon electricity for and how the lack of electricity disrupts your normal operations and day of life. It's what I call that digital darkness. So what I like to do is start with just a kind of a quick pulse check on the state of cyber threats and risks impacting healthcare. And one of the ways I do that is I constantly examine the HHS Office of Civil Rights portal, where all healthcare breaches impacting over 500 individuals must be reported and posted on this public wall of shame, as it's referred to. As you can see, the trending here, it's pretty disturbing. If you look back at 2020 through the most recent totals in 2022, there has been a dramatic increase in hacks. These are external, foreign-based computer intrusions impacting a total of over 112 million individuals in the United States. And I want to point out, when we say individuals being impacted by hacks, 112 million individuals, that does not mean that 112 million healthcare records have been stolen or compromised. What it means is the healthcare records of 112 million individuals have been stolen or compromised. So we're talking literally hundreds and hundreds of millions of records, perhaps billions. 25% of these ransomware attacks, massive increase in ransomware attacks over the past few years. So pretty sobering statistics here. And as you can see, in 2021, we had a 60% increase over the 2020 total. And this year we did surpass even the 2021 record. These are not the type of records that we want to break, of course. So when I look at these breaches, I generally categorize them into three large buckets. The first type of breach impacting healthcare is data theft and data extortion. And here it's those generic type hacks, criminal gangs, foreign-based, financially motivated, trying to steal our PHI and other identifying data that we have on our patients, including of course, their personally identifiable information, payment information, credit cards, bank account numbers, and of course, we have lots of medical research and innovation. A lot of that may be even related to medical device development and medical technology. But it's not just criminal gangs trying to steal our protected health information or our proprietary information for profit. We have very sophisticated nation states, such as China, Chinese government being the most prolific and aggressive, targeting our medical intellectual property. China publishes a 5-year plan, every strategic 5-year plan, every 5 years, and they have a 100-year plan. And within that plan, and this is public information, that part of that strategic plan is for China to become globally dominant by the year 2049, the globally dominant superpower by 2049, not through military means, but by economic means, by being economically dominant, including in healthcare and specifically medical technology. So I know we have lots of folks on today from medical device manufacturers. Think about your proprietary information in your medical technology. Who might be after that for their own economic gain and or to understand the complexity of the software, the design for possible future exploitation once sold and deployed into the healthcare environment. One of the things when I look at this data is we find that the largest bulk thefts of data are not coming directly from hospitals and health systems. It actually is coming from third-party providers who have access to our data and who we have given that data to for other services or functions. Think about in the medical device world, how much data is stored on the device itself, back at your organizations for analysis or facilitation of the delivery care being provided by those medical devices, the function of those devices. So the bad guys here, the point is, have mapped our networks, our internal and external dependencies, and they are going where the data is. So when we talk about third-party risk here, again, very, very significant issue that we have to focus on. How are they doing this? One of the ways is that they're stealing credentials from us. Those phishing emails, very simple way for them to obtain our credentials by deceiving the end user. So business email compromised, but they're also stealing money that way. Once they compromise credentials, they may pose as a vendor or a medical device manufacturer, asking that the customer redirect payment to them. So that's another area that you want to take a very close look at. is on your own vendor structure and how your payments are being processed, and who can change and authorize a change in wiring instructions, and what are your procedures to prevent that. So as I was starting to discuss about the third-party risk, the other type of breach here, the second largest category, is how we are impacted by third-party cyber risk. So as I already mentioned, we have large quantities of data which is stored by significant third-party business relationships. Also, those third-party relationships are being exploited by the cyber bad guys as a potential digital pathway into our organizations. So many of you on this call may be managed service providers in one form or another to support your medical technology. Bad guys have mapped our networks. They understand the internal network and external internet connections we have. So they may target a third party or the managed service providers as the pathway into the hospital. So the attack methodology, it's often what I refer to as the hub and spoke method. They attack the hub, the managed service provider, to gain access to all the spokes, being the customers. And again, sophisticated entities doing this, including the Russian service, exploiting VPN targets. And this relates now directly to the S-bombs that Kevin mentioned earlier. Another insidious way that cyber adversaries are getting into our networks is by understanding what types of technology and software are embedded in our medical devices, for instance, and then developing exploits for that embedded technology. That's why it's very, very important for the manufacturers and the hospitals and health systems to understand the software which is included in those devices. So we have seen, for instance, the SolarWinds attack, Log4j attack, publicly available software that was actually as a building block, a component within third-party software, which was included in medical device. So we actually need to know down to the third and fourth party level, the software which is contained in those devices. So we understand, we, the hospitals and health systems, understand our cyber risk exposure. There's a very significant and very insidious attacks that have occurred recently, which target our mission critical third-party providers when their technology, their mission critical, life critical technology no longer becomes available because they've been targeted with a ransomware attack. I think we're all familiar with the Kronos situation. Again, a business application, payroll application, but it became painfully clear quickly that hospitals and health systems relied on Kronos for far more than just payroll. They relied on Kronos for scheduling of clinical staff. The bad guys, the ransomware attackers, understood that if they attacked Kronos and disrupted their services across the US, there would be significant impact beyond just payroll. We were hit, healthcare was hit by Kronos, felt that impact December 2021, peak of the Omicron surge 2 weeks before Christmas. Another example I talk about is Omnicell, the drug monitoring and distribution, the drug cabinets, which for full functionality must be internet connected. Elekta, they're an organization that provides cloud-based software that runs linear accelerators. Bad guys understood if they attacked Elekta, attacked their cloud, and disconnected them from their customers, those life-critical linear accelerators could not function without connection to Elekta's cloud. So unfortunately, end result, cancer treatment was delayed or disrupted at 170 health systems across the US. Again, creating that pressure on the provider, the managed service provider, to pay the ransom. Not saying Elekta paid, but that's what the objective of these ransomware gangs is, to create that massive pressure by attacking these critical infrastructure, critical parties. So we talk about third-party risk management program, understanding who is life critical, mission critical, and business critical, and those business associate agreements, which for many of you may get more onerous in the coming months, not only due to the FDA pending requirements that will come out, but because hospitals now and health systems are demanding that if you are a life critical, mission critical, or business critical provider, that you have enhanced cybersecurity measures in place and enhanced cyber insurance limitations in place. Of course, the number one issue that we're most concerned about are these highly disruptive ransomware attacks, these high impact ransomware attacks, which disrupt and delay healthcare delivery and risk patient safety. We saw a significant increase in these attacks starting with the pandemic. There were ransomware attacks prior to the pandemic. However, they accelerated dramatically since. And there's a few reasons for that. Basically, our expanded use of network and internet connected technology greatly increased our digital attack surface, which these foreign-based bad guys, primarily Russian-speaking cyber gangs based in Russia or Eastern Europe, immediately began to exploit. Just as recently as last week, again, additional news articles, but additional reports coming out that the ransomware attacks continue at a very, very significant pace across the US. And I think you just have to look at the recent headlines. These are from the past couple of years, but we saw significant attacks right through December and into early January. Sick Children's Hospital, Toronto, Canada, subject of a ransomware attack just before Christmas. What type of organizations attack a children's hospital at Christmas? That group, particular ransomware group, the Lockbit group, sold their ransomware. Ransomware is a service. They are actually managed service providers in a sense, to some affiliate who attacked Toronto Sick Children's Hospital. Lockbit was actually concerned about their own reputation and the government attention and scrutiny that it drew because of that attack, and actually provided the ransomware key for free to Toronto. But that's not the typical case. Most of these ransomware attackers don't care if they're attacking hospitals. And in fact, will seek out targets, will seek out hospitals attack because they understand the urgency, the public health and safety impact, the urgency for these hospitals to restore operations as soon as possible and perhaps be forced to pay the ransom. I wanted to point this one out here, where is a very good example of cooperation between hospital victims and the FBI and the federal government. This past July, a particular couple of hospitals were hit with this unknown strain of ransomware. They immediately called the FBI. The FBI came in and saw, we've never seen this before. But by cooperation of the victim, they were able to work with the FBI. The FBI was able to identify the technical signatures of this malware, attribute it to the North Korean government, and warn the entire field, hopefully, which resulted in the prevention of other attacks. So, and the other benefit here on this particular issue, again, whether you're a medical device manufacturer that's hit by ransomware or you're part of a hospital health system, I would strongly urge you to cooperate, contact the FBI and CISA immediately and work with them. The FBI in this instance was able to recover the ransomware proceeds. They kind of puts a tracking capability in there. Let's just say it's equivalent to an electronic die pack. And they were able to identify and seize the ransom and give it back to the victim. It also helped them push out this reward, hopefully which should have some deterrent effect against these adversaries. Why have I raised this example in particular about the North Korean government? Well, one reason is because of the North Korean government's involvement in the global WannaCry ransomware epidemic from 2017. Some of you may be aware or recall that was a rapidly propagating ransomware, which resulted in, among other things, the disruption of healthcare delivery in the UK. 30% approximately of the UK's national health system hospitals and health systems were disrupted by that attack, canceled surgeries, ambulance diversions. And the thing I wanted to point out here is that it was exploits, vulnerabilities in medical devices, which greatly contributed to the rapid global propagation of this malware. And again, there's the individual who the FBI was able to identify and at least indict that was responsible for the development and deployment of this malware. Certainly, they haven't been arrested, but they certainly can't leave or venture out beyond North Korea. Another ransomware group that we're actively watching very, very closely and currently represents a very clear and specific danger to healthcare is the Dashin Team ransomware gang. Folks, I would strongly encourage all of you that if you have not seen this bulletin, to look at it. It's published by FBI, CISA, and HHS on October 21. We sent out this, rebroadcast it through a special advisory. Please review this and ensure that all of the technical malware signatures have been ingested into your network defenses. These are super bad guys. They are specifically targeting hospitals and health systems. And I can tell you from assisting victims currently, they are very, very active at this point. And again, looking at even the medical devices as a pathway in. Another group here called Hive ransomware, which has impacted US healthcare pretty significantly. And over the holidays, I issued this advisory out to the nation that based upon the activity I was seeing and the uptick in ransomware attacks targeting healthcare, just reminding folks, the bad guys do not take the holidays off. In fact, they increase activity because they assume we will be distracted either by a surge in patients coming in, flu, COVID, and so forth, or simply being many people are on vacation. And unfortunately, that's after that warning, there were multiple hospitals that were hit right through New Year's. This is another ransomware strain, which is very, very, I think, sinister here in their approach and their methodology. What they're doing is developing fictitious profiles based upon publicly available information of real clinicians and emailing legitimate healthcare records, which again may be obtained from medical devices, for instance, and sending them to clinicians working in hospitals and health systems, except that the attached medical record or image may actually have malware embedded in it. So now it becomes an issue of trust. I see this legitimate clinician, practitioner sending me what appears to be legitimate medical records or images from a real patient, but there may be malware in there. So again, what we want to do there is make sure that our endpoint protection and email filters have been updated and are very robust. So with all these ransomware attacks, what has been the impact that we've seen? And unfortunately, now we have many, many examples and case studies of ransomware attacks that we have been able to go back, look at, and really truly understand what the impact is, not just to the security and privacy of data, but to clinical operations. And one of the first things is that often there's an immediate, again, delay and disruption manifesting in itself, for instance, as diversion of ambulances to facilities which are further away. And in rural areas, that's particularly dangerous, especially if you have a trauma patient, stroke, or heart attack patient. We also realized that the unavailability of all the other medical technology beyond the electronic medical record also creates pretty significant disruption and delay to healthcare delivery. So radiology, imaging, all the diagnostic technology, which then becomes unavailable due to a ransomware attack, labs, resulting in surgeries, drug cabinets down, telemetry disrupted, telemetry internally in the hospital and externally to home healthcare patients. And then we experience what we call the ransomware blast radius, where there are, in fact, many organizations that depend upon the victim organization for key medical services. So if you're a large health system, there may be many physician practices which depend on the large system for electronic medical records, radiology, labs, imaging, COVID-19 testing. And for instance, as the situation we had in San Diego, Scripps case, when they were hit, there was a regional disruption. University of Vermont Medical Center in 2020, when they were hit, there was a statewide disruption to healthcare delivery for those particular services. So we have then the simultaneous loss of all medical and information technology systems that are network connected and internet connected. And here's one of the big findings, folks, is that we are seeing that clinical staff are not proficient or unprepared for extended manual paper-based downtime procedures, which could last for up to 4 weeks. So we are seeing the impact of these last for 4 weeks. And in terms of medical device impact, we see some of these factors which may contribute to the delay in the recovery or the functionality of devices. So legacy technology may not be backed up. We may lose that. There's a lack of inventory, lack of physical location, the patch status becomes an issue. Again, that not having that software bill of materials has been an issue when we try to understand where the vulnerabilities or the attack vector may have been in dependency of devices. And then we have like even a strategic organizational structural issue, which creates risk. Often when you have clinical engineering function, which is totally separate from the information security function, there becomes a gap in communication and a gap in understanding of risk and threat by the biomed teams. Again, we see the operational physical security impact, and even third parties, that becomes an issue where third parties may have, one, they may be concerned about themselves being contaminated by the ransomware, and then there becomes a delay in reconnection with these third parties who demand to see certifications that the victim is now clean and there is no ransomware in the organization. So I mentioned briefly Dr. Damef over at University of California at San Diego. Damef, he's really understood and one of the first really to document the regional impact of these ransomware attacks. So when that victim is shut down, hospital is impacted, and then they must curtail clinical operations. Those patients and ambulances are diverted to the surrounding hospitals. And depending upon the capacity of the surrounding hospitals at the time of the attack, it may create significant stress on the healthcare system regionally. And we talk here about the need to develop regionally based cyber incident response plans. And again, we talk about the issue then becomes the delay in care delivery, which creates that risk to patient safety. And we're starting to see some empirical data which does point to negative impacts, as negative patient impacts and harm as a result of ransomware attacks. This paper was just published by Hanan Apresh, which does point out there is the disruption and delay of key services as a result of ransomware attacks. Again, I think it points out or provides empirical data behind what we all know intuitively. If you delay an ambulance, you cancel surgery and cancer treatment, there increases the risk for a negative outcome. Unfortunately, there's more data, this by the federal government, which drew a strong correlation between high impact ransomware attacks and excess deaths regionally and statewide, which surface weeks and months after a high impact attack. Again, same theory that the delay in healthcare delivery, the disbursement of patients to a healthcare system, which may already be under significant strain, meaning that the surrounding hospitals are operating at 75% or above ICU capacity, creates strain, which creates delay and increases the risk of a negative outcome. Again, these reports show correlation. They do not show causation, but certainly as an indicator for us to examine a lot further. So through my advocacy efforts, through the HA's advocacy efforts, our education and working with the FBI, HHS, and CISA, the FBI now officially prioritizes ransomware attacks against hospitals as threats to life crimes, because they understand the potential risk for patient harm that results when you divert an ambulance. We've been very publicly advocating that we need a solution or help assistance from the government, not only on defense, but offense. This is something you don't normally see advocacy organizations talking about, but I do have a lot of experience in counterterrorism issues where we have the same problem set, foreign-based bad guys being sheltered by hostile nation states beyond the reach of the FBI. We can't put handcuffs on them. So we need other alternatives in the use of military and intelligence authorities, existing authorities, to conduct disruptions against them. I'm not advocating that we employ kinetic methods against them, at least not at this point, but we utilize the government, U.S. government's cyber offensive capabilities against these organizations, which continue to attack us with impunity and are being sheltered primarily by Russia, and or in some instances being provided active assistance by the Russians, Iranians, North Koreans. Information here as well, if you ever become a victim, your organization, of a cyber attack, some contact information for you. And also, I always like to point out, your organization has legal, civil, and regulatory immunity when it comes to cyber threat information sharing with the government. I often get asked, John, if we share with the FBI, will they contact our regulator? Will they contact the HHS, OCR? And suddenly then now we are subject to fines and lawsuits, and they are actually prohibited from sharing that information from the regulator. And again, you do have this legal immunity for cyber threat information sharing. Some of the things they'd be looking for there. I know we're going to getting close to time here, so I'll just go over this really quickly. What have we learned from all these attacks? I have literally had thousands of candid and confidential conversations with hospital leaders across the country, many who were victims, victim organizations of ransomware attacks. And here's some of the key learnings and findings that we've seen, is that what we need to do is integrate plans. We need to integrate the cyber incident response plan with emergency preparedness plans, with disaster recovery, with business continuity and downtime procedures. In fact, what I like to talk about is not business continuity plans, but clinical continuity. Very simply put, what is the plan if we lose our technology? How do we continue to care for patients, deliver radiation oncology? How do we do our mission critical, life critical functions without the benefit of technology or communications? Regional plans, those downtime procedures should be in place for every piece of life critical, mission critical, and business critical technology. And then understand what is the impact? What are the third party, second order impacts if we go down? And establish downtime procedures also for those third parties, medical device manufacturers, medical technology. If they're hit with a ransomware attack like Elekta was, what's the plan? How do we continue to deliver radiation oncology? One of the things that I've publicly advocated based upon our finding is to designate downtime coaches and downtime safety officers for each shift in a hospital and health system. What has become apparent is that younger staff, younger clinicians have never really been fully trained or are proficient in manual charting, paper charting, downtime procedures. So designate somebody who has, I don't want to say older, but more experienced person that has been around, is proficient in downtime procedures, and can be that battlefield sergeant should you become victim of a ransomware attack. Network backups, 3D concept, identify triggers for high impact decisions, review that cyber insurance coverage, business associate agreements and requirements. And really for many of you to understand that whenever we talk about the implementation, the integration of technology, there should be a simultaneous collateral and complementary conversation about cyber risk. What cyber risk is being introduced through the deployment of this technology? And of course, the FDA authorities that Kevin spoke about will require medical device manufacturers to have security by design built into the products and have ongoing coordinated vulnerability disclosure. I just put this in for reference as well. This is a great podcast with the CEO of University of Vermont Medical Center, Dr. Leffler, talks about his real world experience there when they were hit with ransomware attack, what worked, what didn't work, and what the best practices and lessons learned were. Again, I'm going to stop here in a moment, and perhaps we'll get to some questions. Kevin already covered a lot of this here in his opening remarks, so I won't talk too much about that. We talked about that. And folks, there are some basic things that every organization should do. And the government, the White House, has implored us to implement these basic cybersecurity procedures, which alone, at a very low cost, could prevent a significant portion of ransomware attacks. Top of the list, multi-factor authentication for all remote access into an organization, then into the databases. Folks, if we're not doing multi-factor authentication at this point, it would be hard to defend both civilly and regulatorily actions against you. It is a very, very basic technique at this point. I think we should all be paying attention to. The increased threat of ransomware attacks is something you want to keep an eye on. The cyber insurers, led by Lloyd's here, the underwriters, are saying that they will stop covering nation-state sponsored ransomware attacks starting in 2023. You know, there's a lot of these ransomware gangs that are provided shelter or have some affiliations with nation states. So stay tuned there. And again, for your own organizations as well. What does that mean? Senator Warner's white paper. I think Senator Warner has done some excellent work, is a significant proponent of cybersecurity in healthcare, was instrumental in getting the medical device cybersecurity requirements included in the omnibus bill, but he's also focused on hospitals perhaps having some minimum mandatory cyber requirements. So we'll be watching that very closely in 2023 as well. And also looking at HHS, Senator Warner is looking at this graph, which is actually not even the complete graph of a link chart of HHS here, but looking to streamline that and appoint cyber, perhaps a single point of contact for cyber. And we are also pushing for clarification on the cyber authorities between CISA and HHS. HHS is designated as a sector risk management agency, but CISA has overall responsibility and authority for protection of critical infrastructure. Performance goals came out for all critical infrastructure. Folks, I want you to take and I'm going to stop here, Kevin. This is really important. This law was passed in January 2021, and HA was instrumental in helping get this law passed with many others. And basically, this provides regulatory relief if you become for HIPAA covered entities that become victim of a cyber attack, if they can demonstrate they've had in place basic cybersecurity, recognized cybersecurity procedures for the previous 12 months. And you get some pretty significant regulatory relief if you can demonstrate that. So Kevin, I think I'm going to stop there. So allow some time for questions, some thoughts. And again, Kevin, I want to thank you and all the great work and advocacy that you've done along with Suzanne Schwartz to get those cybersecurity requirements passed into legislation for the recent omnibus bill. So let me stop there, Kevin.
Thank you so much for the presentation, John. And as you can imagine, we have quite a number of questions. I don't think we're going to be able to get to all of them, but I see one of the most common questions we have relates to carrots and sticks. And I'm curious if, on behalf of the various attendees, if you can comment on what are your thoughts on CMS reimbursement policies, and how can the Joint Commission be harnessed to help the HDO community rise to the challenge of protecting medical device security? Right. So I wonder if you have any thoughts in that space or what might be coming in 2023.
Sure. Obviously, we as an organization, the HA, has thoughts on those issues. We, of course, prefer carrots over sticks, right? We hope that the community, the healthcare community, voluntarily implements consensus-based cybersecurity standards, which were developed, for instance, under the 405D task force, known as the Healthcare Industry Cybersecurity Practices, referred to as HICCUP. We'd like to see that approach. We do know that there is a lot of discussion about minimum mandatory cyber standards, and I think that's something we're going to really have to keep an eye on. If, in fact, there comes a point where there are mandatory cybersecurity standards for hospitals and health systems, the next issue becomes, how do we pay for them? We have many small and rural hospitals that do not have the technical capability, that do not have the financial resources, and quite frankly, the human expertise, the human capital to implement these standards. So, my personal opinion is that I think we need something to incentivize. If there are going to be some sticks, then we need some carrots as well. Perhaps some grant funding, be made available for an increase in CMS reimbursements, for example, that will help fund the implementation of these procedures, or else it is one more unfunded mandate that we must suffer through. And I do remind the government constantly that one of the reasons we're in this situation now with this vulnerable technology is that we were encouraged by the federal government to adopt technology and integrate technology for healthcare records and make meaningful use of technology in 2010, that area, and we were incentivized to do that. However, funding was not provided to help mitigate the cyber risk, which came along with all of that implementation of technology. So suddenly, because cyber threats were not as prevalent at that time, we were encouraged to adopt the technology, but yet now we are left holding on to the responsibility to help minimize that cyber risk that came with that technology. So there's going to be carrots, bottom line, and sticks, the regulation. We definitely need the carrots to help us implement and fund it.
That makes sense. And that comes from a government perspective, and then from sort of the world of outside of government with the Joint Commission. I wonder if you have any comments on that space.
Well, we'll look at that, right? I know we're always concerned about when anything additional is made as a condition of participation. And if this is something that would be assessed by the Joint Commission, I think questions have to be asked. Does the Joint Commission actually have the technical expertise to truly and accurately assess their hospitals and health systems for implementation of cybersecurity? That's a new realm for them as well. So we'd have to see if that really is the best methodology and best vehicle to assess cybersecurity in hospitals and health systems.
Yeah, it's really interesting to see the evolution of experience in different agencies. Even the FDA over the last 10 years has really had a rebirth in terms of its in-house expertise with cybersecurity. So we have a question related to career paths and people interested in getting into the field of medical device security. And so one of the questions is, just off the top of your head, what are a few good career paths forward? I know you went to Northeastern, but what are a few good paths forward toward medical device security management? And whether there's certain certifications or what are you hearing from your members in terms of what they're looking for when they're trying to hire at an HDO for some of these operational technology, cybersecurity aspects? Just anything in that space on, what if there's a student in the audience today or somebody out in the medical device manufacturing world who says, you know what, I want to go into medical device security. What steps should I take? What first step should I take?
Yeah, it's a great question. And I think really it starts with education. With education, if you do not already have pre-existing experience working with medical devices in a hospital or a medical device manufacturer, get that education on cybersecurity. And as you well know, not all cybersecurity roles are purely technical. In fact, what I do is very much on the strategic and management side. And at the same time, getting experience actually working in a hospital, in a healthcare delivery organization, really understanding how the devices are used and deployed, and also absent the education at a college or university, also look for certifications. There's lots of great organizations out there like SANS, for instance, SANS, that offers all types of cybersecurity courses. Getting your certain certifications as a certified information security specialist will also help. And then from there, trying to get the experience, whether directly in an HDO or at a consulting firm even.
Great. So let's see, we have a number of other questions, and I'm trying to search for the ones that are more non-technical. We do have a question about Bluetooth. I know in 2020, there was something called SwinTooth, which was a vulnerability in the wireless communications of just Bluetooth products across the board, just outside of hospitals, but of course affecting healthcare delivery because there's so many Bluetooth devices. And there have been questionnaires circulated on, what risks are at play for devices that use Bluetooth. But I'm just curious, what are you aware of, or even more generally, when there's a vulnerability in Bluetooth or just technology in general? What do you hear from your members, or what comes to mind when just a widely deployed technology has some kind of deeply embedded vulnerability?
Yeah, it's always a concern. And that is one of the reasons why we were so vocal and strongly advocating for the software bill of materials. We need to know the functionality within the devices. We need to know how those devices communicate. Bluetooth obviously is a vulnerability, but generally that requires proximity to the device to exploit the Bluetooth. The majority of attacks that we are seeing actually are coming from network and internet connected devices. There's always that theory that Bluetooth could somehow be used to exploit the function of a device and cause malfunction, like in pacemakers and so forth. We have not seen, there are no documented instances of that actually happening. There are theoretical probabilities that a pacemaker, for instance, could be disrupted by accessing it through Bluetooth. But again, I think some of the fundamental, whatever the transmission method of the data is, that data has to be encrypted, and that the software that is embedded in the device must be patched and secured. So quite frankly, a lot of the attacks that we're seeing start with the very same simple phishing email, which delivers malware into the organization. Often these are not sophisticated zero-day exploitations. Delivering that ransomware in the organization, which then allows the malware to traverse the networks and get into the medical devices. Now, embedded software such as when we had the attacks on the Log4j exploitation of vulnerabilities deeply embedded, and or SolarWinds, that is a significant issue, but not as common as the typical phishing email that delivers more common malware into the organizations.
Well, it's interesting that the sort of tried and true, the old techniques continue to be the prevalent, the spear phishing and such.
Right. And when I mentioned the DASN ransomware alert, because I did that for a reason, specifically because we're seeing the bad guys are still exploiting the published vulnerabilities. And quite frankly, the way the bad guys are getting in is they are exploiting these known and published vulnerabilities. They're simply beating us to the patch. So we talk about the need to try to expedite the patching processes. And we know it's difficult with medical devices. You can't just roll out a patch because you have to test it, make sure it's safe, make sure it doesn't break the device or cause a malfunction, which could potentially risk patient safety. And also, there's always this discussion I hear, John, the medical device manufacturer said they can't patch or upgrade without FDA approval. And that's just simply not the case. It's not true. The FDA authorizes basic patching, security patches, and upgrades, which don't affect the functionality without the approval of FDA. And we stress that quite a bit.
And it's interesting to look in the omnibus bill where that makes it even more clear of patches and updates being expected now by law.
By law, that's right. So we look forward to the work that the great work you've done at FDA with Suzanne Schwartz there. And I'm sure that Suzanne and the FDA, of course, will use their new authorities in a very judicious way. And we hope to continue to be part of that conversation with the medical device manufacturers.
Right. So we have only time for one more question. We have many, so I apologize we're not able to get to all of them. I want to talk about a slightly different topic, just to round things out, and back to ransomware. We have a question about ransomware attacks on US hospitals versus the larger ecosystem outside the United States. Now, of course, the A stands for American in AHA, but I'm curious on behalf of one of the attendees, just what are you hearing perhaps from counterparts in other countries? Is the US a bigger target? What's going on internationally?
It's a good question. We are a bigger target, but we are not alone. There have been many highly publicized attacks against hospitals and health systems in Western Europe, in Canada, where I mentioned the Sick Children's Hospital in Toronto. So the government agencies are collaborating, and we're also starting to collaborate with our colleagues across the globe. And in fact, I'll be doing some work with the International Hospital Association this year, where they have in fact designated cybersecurity as their top issue for 2023. So it's that collaboration that we all have to do. The bad guys are sharing information, they're cooperating. We need to do the same to help defend against their attacks.
Well, I'd like to give you just a few moments for closing remarks. We have about a couple minutes left. Again, thank you, John, for sharing your thoughts today from the perspective of the American Hospital Association. So any closing thoughts for our audience?
Again, Kevin, first, again, thank you again, you and all the great work that you've done with Suzanne Schwartz at the FDA. You're helping make the nation safer by helping against cyber threats, by helping secure medical devices. So again, on behalf of the American Hospital Association, we appreciate the interest in the topic, and that I would strongly encourage all of you to work together and collaborate, whether you're a medical device manufacturer or an HDO. Collaborate on cybersecurity, because ultimately all of us depend upon hospitals. We depend upon their availability. Everyone uses a hospital at birth and at death. Generally, they're in a hospital. So again, we ask everybody to cooperate, collaborate, share information, work with the federal government. When you become a victim, if you become a victim of a cyber attack, or if you have cyber threat information to share, contact the local FBI office, contact the local CISA coordinators, share that information, help make us all safer. So appreciate what everybody is doing here, especially our clinicians and providers. Thanks for the care that you provide, and thanks for your service to our communities.
Yes. Well, thank you, John, and thank you everyone for joining today. That is the end of today's seminar series. We'll be back again every third Thursday of each month. And thank you again for joining.